Thanks for having me. I have no financial disclosures. So I'm just going to preface briefly by going over the preoperative workup for our allografts. So for all recipients, we will check these labs. For potential living-related donor and recipients, we'll do ABO type-in, HLA type-in, and then perform a virtual cross-match. For all recipients, we'll check PRA and donor-specific antibody. For all potential donors, we do check for certain viruses as listed there. So what is PRA? So PRA is panel reactive antibodies, a screening test for a range of known antigens. Basically, it's the percentage of random donor organs a recipient would react to based on preformed antibodies. It's it's listed as a percent from 0 to 100. Basically, 0 showing that you have a low risk of rejection, 100% high risk. And it's thought to be elevated when you have a history of exposure to non-self antigens. Why is it important? In this other solid organ transplant literature, a high PRA has been shown to have worse outcomes following transplantation. And so we've incorporated this into our immunosuppression protocol. I'm going to go over this briefly. This is our protocol that we've developed with organ transplant specialists at the with the University of Cincinnati. And so we'll start patients on tacrolimus and mycophenolate mofetil a couple weeks prior to surgery to make sure that they tolerate the medications well. We'll also have them on prednisone for the first 1 to 3 months following surgery. Early after surgery, we'll titrate the trough level of tacrolimus to 8 to 10. At around 6 months, we can lower this target to 5 to 8. Around 12 to 18 months, we can start tapering and discontinue tacrolimus if there's no signs of rejection and they're doing well. And around 3 to 5 years, we can consider discontinuing medications if, again, they're stable and no rejection. For high-risk patients, so if they have a high PRA or they're a repeat transplant patient, typically we'll start them on earlier systemic immunosuppression, have them on for longer, potentially even indefinitely. If they have PRA greater than 50%, we'll consider an infusion of basiliximab, which is a monoclonal antibody against the IL-2 receptor for T cells. And this is to prevent early rejection. And so we'll have them undergo this infusion right before surgery as well as 4 days postoperatively. Postoperatively, we continue to monitor labs every month with those labs listed there. We'll also check blood pressure, have them undergo routine cancer screening, and continually monitor for adverse events. We'll have them on prophylactic antimicrobials for opportunistic infections. So we'll have them on 3 to 6 months of valganciclovir for CMV prophylaxis, and in Bactrim for 6 months for PCP pneumocystis prophylaxis. At each examination, we continue to evaluate the ocular surface, looking for signs of recurrence of stem cell deficiency, so partial failure or failed ocular surface. We'll also look for signs of immunologic rejection. In our 2013 study that was published, we divided this into severe rejection and low-grade rejection. And so for severe rejection, it was we saw signs of moderate to severe pain and intense sectoral or 360 injection, versus low grade had more mild discomfort, mild injection. Both types had edema and nevascularization of the stem cell segments. Both had epithelial rejection lines and other signs of abnormal epithelium. And here are some examples. In the top left, you can see a severe rejection episode. In the top right, it's a more quiet eye, but you still have injection edema of the KLL segments. In the bottom left, you have an epithelial rejection line. You can see there in a setting of severe rejection. And the bottom right, you have an epithelial rejection line in an otherwise quiet eye. And so that is low-grade rejection. We treat rejection by increasing local immunosuppression, typically with every 1 hour difluprednate. But we can also consider injecting subconjunctival corticosteroids right into that area, especially if there's only a sector that's affected. We'll also want to increase systemic immunosuppression with high-dose prednisone that's tapered over a couple weeks, and also consider increasing tacrolimus and mycophenolate. The figure is from a recent review of all our eyes that we had follow-up for greater than 5 years. We found that 54% had undergone at least one episode of rejection. And looking at the outcomes of that, so 25% were reversed successfully with medical therapy, and then but 75% underwent or ended up going on to have either sectoral failure or total surface failure. And so for us, the biggest goal is to prevent that very first episode of rejection. Late failure is when you have signs of stem cell deficiency again, or late staining in this otherwise quiet eye. It can be from prior episodes of immunologic rejection, non-immunologic inflammation, as well as chronic exhaustion of donor stem cells. We found that some of these cases are corticosteroid responsive, and so we'll often have a trial of steroids to see if they're able to reverse this, but often this necessitates repeat stem cell transplantation or possibly keratoprosthesis. We'll want to treat persistent epithelial defects pretty aggressively and be vigilant about them. And so treatment is typically repairing the underlying eyelid abnormality, decrease in exposure, lateral tarsorrhaphy, bandage contact lens, treating the tear film abnormality, and if there's a regular epithelium or breakdown from the stem cell problem, then we'll want to treat that. Microbial keratitis is a problem in this population. Looking over the last 10 years, we've had about over 20% that have had an episode of infectious keratitis, and about a quarter to a third of those are fungal for risk factors that are listed right there with epithelial defects, being on immunosuppression, as well as chronic antibiotic use that we have them on. And so we want to treat them aggressively with antimicrobial agents, stop the corticosteroids while we're treating them, possibly decrease systemic immunosuppression, and if the infiltrate is moving towards the graft-host junction or towards the sclera, therapeutic keratoplasty is indicated. These patients often have glaucoma because of an underlying condition that was associated with the stem cell problem, also because they're post-transplant, and also because we have them on long-term steroids. And so we work to co-manage co-manage glaucoma with our glaucoma specialists. This often necessitates drainage devices as well as a diode cycle CPC, especially if there's Conge disease. So in conclusion, the postoperative management necessitates close monitoring for adherence of systemic immunosuppression, rejection, ocular surface instability, microbial keratitis, and glaucoma. And vigilant postoperative care helps to maintain a long-term stable ocular surface. Thank you.
Thank you. Okay.